Good afternoon. Thank you very much for attending the talk. So my name is Yanda, and I'm a junior doctor at James Cook University Hospital, but I'm also in the uveitis service at Moorfields as well. So working with Dr. Cox and Mr. Young. So a general brief overview of my session. So I've divided into broadly 4 parts. So starting with some epidemiology, why syphilis is becoming more and more important, the classification and manifestation of syphilis, and then finish off with how to diagnose it and how to manage it. So syphilis has actually been around for quite a while now. It was first recorded in the 1400s, and the bacteria that actually caused syphilis was actually identified in the early 1900s. And the successful treatment by using penicillin was actually discovered in 1943. And this has actually made a dramatic difference. For example, in the UK, before 1999, syphilis has actually become quite rare in the country. However, since 1999, we've been seeing a sustained outbreak in this country until today. I'm sorry about these lines. I don't know why they're here. But if you just ignore these lines, the red ones. So this is a graph taken from the government website regarding the number of syphilis by gender. As you can see that males are a lot more affected by syphilis compared to females. And in the year between 2013 and 2018, there has actually been an increase of about 124%. And in 2019, there were about 8,000 cases of syphilis reported in England, and this was a 10% increase compared to 2018. Oh, sorry. And if we then divide the diagnosis by sexual orientation, we can see that these pink ones are men who have sex with men. And we can see that the majority of syphilis that were diagnosed were made among men who have sex with men. And if we take 2018 as an example, this accounts for about 80% of all the syphilis that were diagnosed in this single year in England. And if we break it down to gender and also age, as we can see here again, as I've mentioned before, syphilis rates were on average about 17 times higher among men compared to women of the same age. However, syphilis diagnoses are actually more evenly distributed across different ages compared to some of the other sexually transmitted diseases. And as you can see, among women, the rates were the highest at a younger age, so between the age of around 18 to 23, whereas for men, the rates were they peak at around early 30s, so a few years later than women. So in order to tackle the ever increasing syphilitic diagnosis in England, Public Health England, in other words, PHE in short, has produced this document called PHE Action Plan in order to tackle this increase in syphilis. And in this document, it was broadly divided into 4 prevention pillars. So ranging from increasing the testing frequency in order to identify patients, to deliver partner notification to these patients who are diagnosed with syphilis, maintain high antenatal screening coverage to try to reduce and minimize congenital syphilis, and also sustain targeted health promotion. So when we talk about syphilis, it's actually a disease in itself, and the causative organism is actually called Treponema pallidum. You can actually visualize this under the microscope, and what you will see is like this, which is a coiled motile spirochete, like helical spirochete. And actually humans are their only natural host. And due to our current limitation on culturing technique, there is actually no in vitro culture at the moment. Therefore, the study on syphilis is quite heavily dependent on animal models. And in this case, we use rabbits. And this is because rabbits have been noticed to have a very similar sexually transmitted infection by another treponema organism, which can also lead to quite similar signs and symptoms. So transmission of syphilis is actually by direct contact with mucocutaneous lesions. And transmission is almost always by sexual contact. However, it can be vertical as well, which will cause congenital syphilis. And this is because these bacteria are quite small, so they're small enough to cross the placenta. Oral fecal route is also a possibility, but it's quite uncommon. And it's important to mention that exposure, although can generate partial immunity, but if the patients were treated rapidly with effective treatment, this can actually prevent development of further immunity. What it means is that reinfection is possible on subsequent exposure in these patients. So syphilis is, or can be divided into, broadly speaking, 4 different stages. And this is based on the time after exposure and also the symptoms and presentation, symptoms and signs. And those are primary, secondary, latent, and then tertiary. And it's important to know that for patients with primary syphilis, if left untreated, about a quarter of them will develop, will progress to secondary syphilis. And for all the patients with secondary syphilis, if left untreated, all of them will eventually progress to latent syphilis. So if we start talking about primary syphilis, there's an incubation length of about 90 days. However, clinically speaking, this is usually about 2 to 3 weeks on average. And they will develop a lesion at the site of inoculation, which is shown like here, which are called cancres. And these have very well-defined edges with indurated bases. And they normally will heal within 3 to 10 weeks. Some patients will also experience local lymphadenopathy. And it's important to mention that these cancres are painless. Therefore, it's important to suspect syphilis with patients present with any ulcers. So when these patients progress onto secondary syphilis, this normally happens about 4 to 6 weeks after the primary lesion. And patients will present with symmetrical maculopapular rash and accompanied by constitutional symptoms, which, for example, are fever, headache, generalized lymphadenopathy, and also anorexia. And it's important to note that the centrifugal spread of the maculopapular rash involving the palm and the soles are quite typical of syphilis. And it is at this stage when the ocular involvement is actually the most likely. And then they can progress to latent syphilis when they will have no symptoms or signs at this stage, because the definition of latent syphilis is that these patients have serological proof of infection without any symptoms of the disease. And when they become, or when they go into latent syphilis, there's a risk of them progressing to tertiary syphilis, which is about 20 to 40%. And the distinction, if you could remember from previous slides where I showed the table, between early latent and late latent is the number of years they have had the infection. So tertiary syphilis can be actually broadly again divided into 3 main categories. So neurosyphilis, cardiovascular syphilis, and also gametes. Neurosyphilis, as you can tell from the name, it can affect either meningovascular parts or it can affect the parenchymus parts and causing things like general paresis or tabes dorsalis, depending actually on if neurosyphilis happened early on in the disease course or later on. Cardiovascular syphilis can manifest as things like valvular problems, heart failure, or aortitis. And gametous syphilis is when patients develop these inflammatory granulomatous destructive lesions. And this can actually affect any organs, but the most commonly affected organs are bones and skin. So this is a summary slide of syphilis stages and how it can develop. And it's important to mention here that neurosyphilis, as you can see here, encompasses a huge spectrum from very early on of the disease to quite later on, which is part of the tertiary syphilis. So when we talk about ocular manifestation, although as mentioned before, it is quite common in tertiary and secondary syphilis, can also be in other stages of the syphilis. So for patients with congenital syphilis, they normally present with interstitial keratitis or dislocation of the lens. Although it is quite rare for patients with primary syphilis to have ocular involvement, they could actually develop these ulcers, the cancri, as in primary syphilis, on the eyelid or the conjunctiva if they've had contact with the bacteria or the mucocutaneous lesion containing these bacteria. When patients have ocular manifestation in secondary or tertiary syphilis, this can virtually involve any part of the eye, so ranging from conjunctiva to the sclera, you can have uveitis, can have retinitis, and sometimes the optic nerve can get involved as well. And it's important to know that for patients with ocular manifestation, usually speaking, they may not have systemic manifestation like the fever, rash, and stuff. And this is often because when patients present with ocular problems, their systemic problems would have already resolved. Because this talk is primarily based within uveitis, so I'll be talking very briefly over how syphilis can cause different types of uveitis, and namely, as you've heard before, it's divided into anterior, intermediate, and posterior uveitis. So when syphilis causes anterior uveitis, it actually starts off normally as an acute unilateral iridocyclitis. And in about 50% of these patients, their second eye can also become involved. And this uveitis can range from actually mild non-granulomatous uveitis to severe granulomatous uveitis, where you can see on the slit lamp either these keratic precipitates, so white cell collection on the cornea, or you can sometimes see the iris nodules on the iris. Sometimes you can also see this iris roseola, which is shown here, which are dilated iris blood vessel tufts, which are quite characteristic of a syphilitic cause of anterior uveitis. It is important to be alert of poor response to topical steroid treatment, as you've heard previously, which is the mainstay of treatment for uveitis in idiopathic form, because this could be a hint that these patients may need actually specific antibiotic treatment because syphilis is the cause of their anterior uveitis. So syphilitic eye disease can lead to intermediate uveitis, and this is especially true if there's mild inflammation of the anterior segment that is associated with a more pronounced vitreal reaction. And this intermediate uveitis can also be associated with retinal vasculitis, cystoid macular edema, or a hot disc. Snowbanking, which is the accumulation of vitreous exudate over the pars plana, so the pars plana exudate, it can occur in syphilitic intermediate uveitis, but is actually quite rare. So when syphilis causes posterior uveitis, it can actually thrive in all the layers at the back of the eye. And therefore, it can cause things like chorioretinitis, which is actually the most frequent manifestation. And this is often associated with a significant degree of vitreous inflammation. And in this, fluorescein angiogram will normally show early hyperfluorescence of the lesion, which is followed by late staining. It can also cause retinitis, which is often associated with retinal vasculitis, which is characteristic of syphilis. It can be patchy early on, but then become confluent over time. It's important to bear in mind that retinitis of this is quite difficult to be distinguished from acute retinal necrosis or toxoplasma retinochoroiditis, especially when they all can present with heavy vitritis. However, the good thing about syphilitic cause of retinitis is that it's very responsive to penicillin. The acute syphilitic posterior placoid chorioretinopathy is an uncommon but clinically and angiographically distinct manifestation of ocular syphilis. And this is actually an infection of the retinal pigment epithelium in the macula or the peripapillary region. And what you see is those large solitary placoid, kind of pale yellowish subretinal lesions with some vitreous cell infiltration, and this usually affects both eyes. And these lesions will normally show central fading and a pattern of coarsely stippled hyperpigmentation of the retinal pigment epithelium. On the OCT, you will see the nodular thickening of the retinal pigment epithelium, and on the fluorescent angiogram, as you can see on the top right corner here, you can see the small leopard spot alteration of the retinal pigment epithelium. And in addition, there's actually a distinction between acute and chronic syphilitic posterior uveitis, where the acute type is more associated with secondary syphilis, where patients have florid and rapidly progressive uveitis, and patients normally will have also progressive visual loss as well. Whereas chronic is more of a manifestation of tertiary syphilis, where this is quite insidious and can be associated with subclinical neurosyphilis, and where patients will have a milder form of inflammation. So in order to diagnose syphilis, there are broadly speaking two main categories of tests we can use. One is the direct test, where you detect or visualize the causative organism directly, and the other is by serology. Dark field microscopy is one of the two main types of direct methods. It involves the examination of the serous fluid that's collected from the lesion, and it's quite time dependent because you have to examine no later than 20 minutes after the collection. So it's got quite a bit of limitation. This is actually no longer the gold standard for examining or diagnosing genital cancri for the primary syphilis. So PCR swab is another direct method for detecting the causative organism, and this can be used in any ulcerative lesions, and is quite sensitive and specific, and it is used in conjunction with the serology testing we're going to talk about now. So syphilis serology is actually divided into two parts: the troponomal test and the non-troponomal test. The main difference between these two is one is a specific test, as you can see written here, and the other is non-specific. And the reason they're called these is, although they both test for antibodies, but for the troponomal, the specific tests, they're testing antibodies against antigen that's on this causative organism, troponomal pallidum. Whereas the non-specific tests test for the antibodies that's produced by the damaged human cell because of syphilis or because of the invading organism. So troponomal tests are divided into two main tests. So you can either use ELISA, which is a screening test, or you can use TPPA, which is a confirmation test. And non-troponomal tests include two main ones are RPR and VDRL. And these two, again, are sometimes used in conjunction, so at the same time in patients, because they each have their advantages and disadvantages, so they can complement each other. For troponomal tests, they will remain positive for life, whether the patients were treated or not. Therefore, it can't really be used to differentiate active from old disease. And also its level is not corresponded with the disease activity either. For the non-troponomal tests, although it does have a high false positive results or high false positive rates, it is it can be quite sensitive in the early on of the disease, and its level is actually corresponding to the disease activity as well. And this is why it can be used as a monitoring test. And at the moment, I believe for RPR, the consensus is a fourfold decrease in theta, and because they're done in serial dilutions, a fourfold decrease in theta can be an indication of disease regression. So that's quite useful in monitoring treatment when you give patients antibiotics. So there are two actually other tests that you might consider as well. One is the cerebrospinal fluid, and this is especially important if the patient is either HIV positive or have neurological or ophthalmic or like auditory involvement. And the other one is HIV test. And this is because co-infection of HIV and syphilis is quite common due to the shared risk factors that's related to sexual behavior. In addition, the syphilitic cancri we talked about, they can increase the risk of acquiring and transmitting HIV. And also in these patients, they may have high bacterial loads, so high syphilis bacterial loads, and they're more prone to neurosyphilis development. In addition, their ophthalmic involvement can often be bilateral, more aggressive, and they may relapse despite giving them adequate treatment. And in addition, in these patients, they're more likely to have false positive or false negative when you do the serological tests on them. So now moving on to management of syphilis. So the British Association for Sexual Health and HIV, or BASH in short, published a guideline in 2015. In contrary to what people may think, it's quite simple actually how to treat syphilis. The antibiotic of choice is penicillin, and regardless of which stage the patient's at, it's almost always penicillin. And the difference lies in the route you give the penicillin to the patient, the dose you give the penicillin to the patient, and also the length, like how long you give penicillin to the patient. That's the only difference, or the main difference. So if the patient has neurosyphilis, which includes neurological or any ophthalmic involvement, it's still penicillin that you give. And you give either by intramuscular injection or intravenous injection. The alternative regimens include doxycycline, amoxicillin, or ceftriaxone. And steroids actually should be considered or given with the antibiotics if the patient presents with neurosyphilis. And it's important to note that management is the same regardless of where, like which part of the eye is involved. If you would like to know in details how to treat different stages regarding the specific details, you can actually go on BASH, and they have a very, very good guideline. I've also involved the link in my reference slide as well later on. So in conclusion, syphilis, as we all know it, is known as the great imitator. Therefore, it's always important to think of syphilis at the back of your minds when you meet the patient. And in the UK, how we do it is we refer patients to journals for urinary medicine, where they can get screened for other sexually transmitted diseases and be given the appropriate antibiotic to be treated, which is penicillin, as we've said before. So these are my references, and this is the BASH reference I talked about. So you can either Google or just click on that. And I'd like to thank my team who helped me produce this slide, especially Professor Pavasio and Mr. Young for giving me the opportunity to participate in this talk. And thank you very much.